Imagine your body's most critical survival alarm is, well, just completely muted. Like your blood sugar drops to a fatal level, your brain literally starts shutting down, and you feel absolutely nothing.
Yeah, no sweating, no racing heart, nothing.
Right. No warning at all. And for a really specific subset of type 1 diabetics, this is just a terrifying daily reality. But what if we could just, reinstall that broken alarm system using an infusion of lab-grown cells?
I mean, we are getting incredibly close to that exact reality. Like when you step away from the sci-fi movies and look at the actual data coming out of laboratories today, the future of medicine doesn't look like nanobots or magic pills. It looks like highly coordinated, hyper-targeted biological engineering.
Welcome to the deep dive. For you listening, our mission today is to explore the absolute bleeding edge of modern medicine. We have a stack of sources here detailing 3 distinct phase 3 clinical trials, and they really serve as the architectural blueprints for tomorrow's treatments.
And we should point out, these aren't just any run-of-the-mill trials. Out of a possible 20 points for breakthrough potential, these 3 share a massive score of 18.
Wow.
Yeah, and their overall TrialsAlert scores are hovering right around 90 out of 100. In the medical research world, a score like that is basically a neon sign flashing, demanding attention.
It's just huge.
It really is.
No.
A score that high suggests the medical community is anticipating a true paradigm shift. We're looking at a fundamental move away from purely reactive medicine, where doctors just manage symptoms as they pop up toward highly targeted upstream interventions.
And we are going to look at these upstream interventions across 3 of the most daunting diseases out there, right? Alzheimer's, type 1 diabetes, and breast cancer. So let's just jump right into the neurology domain. Our first source is a trial sponsored by IZ Inc., and it's known as the AHEAD 345 study.
Right, so this phase 3 trial is evaluating a drug called Lecanemab, and they're comparing it against a placebo. The scale here is significant. They are enrolling 1,400 patients across 107 different clinical sites globally.
Okay, let's unpack this target demographic, because this is where the trial completely flips the traditional script. They aren't looking for patients who are actively suffering from severe late-stage Alzheimer's dementia.
No, not at all.
The source explicitly states they are targeting participants with preclinical and early preclinical Alzheimer's disease who have elevated or intermediate brain amyloid.
And that distinction, that changes everything about how we treat neurodegeneration. So amyloid refers to these protein fragments that just naturally occur in the brain.
Okay.
In a healthy brain, these fragments are broken down and eliminated. But in Alzheimer's, they accumulate and clump together into these hard, insoluble plaques right between the nerve cells.
And that's what causes the damage.
Exactly. For decades, the medical community has observed that these amyloid plaques are basically a biological hallmark of the disease, and they set off this whole cascade of inflammation and neuronal death.
So is treating preclinical Alzheimer's basically like trying to clear the dry brush from a forest before a spark hits? Yeah. Rather than, trying to put out a raging fire?
That is actually a remarkably accurate way to picture the mechanism, because by the time the fire of clinical Alzheimer's is really raging, like when a patient is experiencing significant memory loss and behavioral changes, the structural damage to the brain's architecture is already extensive.
The brush is already burned.
Right. Neurons have died, brain tissue has literally shrunk. You cannot easily reverse that level of physical destruction. So, the AHEAD study tests the hypothesis that lecanemab, which is a monoclonal antibody designed to bind to these amyloid clumps and flag them so the brain's immune system can clear them out, that it can actually remove that dry brush.
Oh, wow.
Yeah, so if you clear the brush early enough, you might slow or entirely prevent the cognitive decline before the outward symptoms ever even escalate.
A decade before symptoms.
Yeah.
That totally reframes how we view Alzheimer's. We think of it as this old age disease, but biologically it's actually like a middle-aged disease that just takes 10 or 15 years to finally reveal itself.
That's exactly it. It's a very slow, insidious process.
But wait, here is my major question on the logistics of this.
Yeah.
Looking at the trial specs, it notes that the results for this study are expected after 216 weeks of treatment. That is over 4 years.
It is a massive time commitment, yeah.
Right. So if I'm a patient in this trial, you're asking me to take an experimental drug for half a decade just to prove I didn't lose my memory. How do researchers even measure success over that timeline?
Well, you are hitting on the ultimate challenge in preventative neurology here. Like we said, Alzheimer's pathology is notoriously slow. So if you're running a trial on preclinical patients, people who feel perfectly fine today, but maybe have the biological markers on a brain scan, you are essentially waiting to observe a decline that doesn't happen.
Proving a negative,
Yeah.
which requires an agonizing amount of waiting.
Yes, it requires immense patience and an incredible volume of data. To prove lecanemab works in this specific preclinical population, researchers have to track all 1,400 patients for those entire 216 weeks.
Just to see if the placebo group gets worse.
Exactly. They are waiting to see if the statistical curve of the placebo group starts to bend downward into cognitive decline, while the group receiving the antibody remains stable. It takes 4 years just to get enough statistical divergence between the two groups to definitively prove the intervention was the cause.
Which perfectly explains why an 18 out of 20 breakthrough score here is so wildly significant. Pulling this off isn't just releasing a new drug.
No, it's proof of concept.
Yeah, proof that humanity can intercept one of its most feared diseases before the patient even knows they are sick.
Yeah.
It's like the ultimate preemptive strike.
A preemptive strike in the brain is an incredibly elegant solution. But, sometimes prevention is no longer an option.
Right, which brings us to our next trial. So Vertex is trying to carefully rebuild a destroyed system in diabetes patients. If the Alzheimer's trial is about clearing the tracks before the train wreck, our second source looks at what happens when a vital bodily system is already fundamentally broken. We have to move from slowing a decline to actually replacing biological function entirely.
Yeah, this shifts our focus over to the endocrinology domain. We're looking at a phase 3 study by Vertex Pharmaceuticals for an intervention called VX-880. And we use the word intervention because VX-880 is not a traditional chemical drug. It is a highly advanced cell therapy for type 1 diabetes.
And the patient profile outlined in the source is incredibly specific. Like, they aren't opening this up to just anyone managing diabetes.
No, not at all.
This trial is targeted at adults who suffer from impaired awareness of hypoglycemia and severe hypoglycemia. The stated goal here is to reduce these severe low blood sugar events and lessen the patient's dependence on insulin injections.
Right, and we really need to ground this in the physiology of what impaired awareness actually means for a patient. So normally, a rapid drop in blood sugar triggers a massive release of adrenaline. The body starts shaking, sweating, the heart races.
Like a physiological screen to eat some sugar immediately.
Exactly, but for some individuals with long-standing type 1 diabetes, the nervous system eventually just stops releasing that adrenaline. The warning system breaks down entirely. Their blood sugar can plummet to life-threatening levels, and they feel perfectly fine right up until they suddenly lose consciousness or go into a seizure.
That is terrifying. Using a cell therapy like VX-880 for this sounds less like taking a daily maintenance pill and more like, I don't know, installing a brand new internal thermostat for blood sugar.
That's a great analogy.
But physically, how do you install a new thermostat? I mean, they aren't doing open pancreas surgery, right?
No, and the procedure is actually a marvel of modern medicine. So in type 1 diabetes, the body's autoimmune system has mistakenly attacked and destroyed the islet cells in the pancreas. Those are the specific cells that manufacture and release insulin.
Okay, so the factory is broken.
Right. So VX-880 consists of fully differentiated insulin-producing islet cells that have literally been grown in a lab from stem cells. And instead of operating on the pancreas, doctors infuse these new cells directly into the hepatic portal vein, which leads straight into liver.
Wait, hold on. They put pancreatic cells into the liver.
They do, because the liver provides this incredibly blood-rich environment. The infused islet cells just settle into the small blood vessels of the liver and graft themselves and essentially set up a new biological factory right there.
That is wild.
They monitor the blood sugar flowing through the liver and release insulin accordingly, basically acting as a functional cure.
That is absolutely mind-blowing. But looking at the trial specs, I am seeing a glaring contrast here.
Yeah.
We just talked about an Alzheimer's trial with 1,400 people. We'll be talking about another massive trial in a minute. But this Vertex diabetes trial is only recruiting 52 patients across 29 sites worldwide.
Yeah, it's a very small cohort.
Why such a tiny number for a phase 3 trial that has the exact same 18 out of 20 breakthrough potential as the others?
Well, small numbers in phase 3 usually indicate extreme specialization and very high stakes. You have to remember, VX-880 is not currently meant to replace standard insulin therapy for every single person with type 1 diabetes.
Because it's too intense.
Because these are foreign cells being introduced into the body. The patient requires chronic immunosuppressive drugs so their immune system doesn't just reject the new thermostat.
Ah, okay. So they have to balance the risk of suppressing the whole immune system against the risk of the disease itself.
That's the exact crux of it. For a healthy diabetic who manages their blood sugar well with an insulin pump, taking heavy immunosuppressants is just too dangerous. The math doesn't work. But researchers are targeting this highly vulnerable subgroup, the people who have completely lost their hypoglycemic awareness.
The people who could pass out at any second without warning.
Exactly. For these 52 patients, the risk of falling into a sudden fatal coma while driving or sleeping far outweighs the risks associated with immunosuppression. So the small size of the trial really reflects the intense precision of this intervention. It is cutting-edge, highly complex endocrinology reserved strictly for those in immediate life-threatening danger.
Wow. Okay, so we've looked at preemptively clearing harmful proteins in Alzheimer's. We've looked at carefully replacing broken cellular systems in diabetes. But when you look at Merck's approach in our final trial, careful is like the last word I'd use. They aren't rebuilding anything. They're deploying a scorched earth policy against an active, aggressive invader.
Yeah, the strategy in oncology requires a completely different mindset. You have to deploy a highly coordinated, overwhelming attack to outmaneuver the cancer's ability to mutate and survive.
And the scope of this final phase 3 trial is staggering. We are looking at a study sponsored by Merck evaluating a new targeted therapy called Sacituzumab Tirumotecan. They were combining it with an immunotherapy drug called pembrolizumab, plus just a shockingly long list of heavy-hitting chemotherapy drugs.
It is a massive cocktail.
The source lists an arsenal that includes, carboplatin, paclitaxel, doxorubicin, cyclophosphamide, and olaparib. I mean, the list goes on.
They are literally throwing almost every mechanism of action we have at this disease. The target they're aiming this arsenal at is high-risk, early-stage triple-negative or HR-low positive, HER2 negative breast cancer. And the scale totally reflects the ambition here. 2,400 patients globally across 268 different clinical sites.
That is huge.
Yeah. The primary goal is to rapidly reduce the number of cancer cells in both the tumors and the lymph nodes, ultimately helping these patients live longer without the cancer progressing at all.
The analogy that immediately jumps out here is military. It's like calling in a highly specialized SWAT team, which is the targeted therapy, Sacituzumab Tirumotecan, alongside the traditional heavy infantry, which is that massive list of standard chemo drugs. And they are working simultaneously to take out a very hardened target. But triple-negative breast cancer is notoriously aggressive. Why does throwing this massive combination of therapies at an early-stage cancer mean doctors are fundamentally changing how they strike?
Well, historically, in early-stage cancers, the philosophy was often sequential. Doctors might start with surgery, follow up with one type of chemotherapy, and maybe hold back some of their heaviest weapons in reserve just in case the cancer returned or spread later.
Keep your powder dry, essentially.
Right, but triple-negative breast cancer is uniquely resilient precisely because of what it lacks.
The triple-negative refers to the receptors, right?
Right, yes. The cancer cells do not have estrogen or progesterone receptors, and they don't make much or any of the HER2 protein. Those three receptors fuel most breast cancer growth, and consequently, we have highly effective hormone therapies and targeted drugs that block them. But because triple-negative lacks those receptors, all those standard treatments just bounce right off.
It's like a tumor wearing armor.
Exactly. It's a tumor that doesn't offer many targets, making it incredibly dangerous.
So if the tumor is practically wearing armor against standard therapies, how does this new SWAT team actually breach the walls? And why combine it with so many other drugs all at once?
Okay, so Sacituzumab Tirumotecan is an antibody-drug conjugate, which you can basically think of as a guided missile. The antibody part is engineered to seek out and bind to a specific protein called TROP2, which is overexpressed on the surface of these specific cancer cells.
So it hones right in on them.
Right. Once the antibody attaches to the cell surface, it gets absorbed inside where it drops its payload, which is a highly toxic chemotherapy drug, directly into the tumor, sparing much of the surrounding healthy tissue.
Okay, so the guided missile blows the doors off the cancer cell. But why follow it up with drugs like paclitaxel or olaparib?
We have to look at how they synergize to totally trap the cancer. While the guided missile is destroying cells from the inside, you bring in the heavy infantry. Paclitaxel works by literally freezing a cancer cell's internal scaffolding so it physically cannot divide and replicate.
Wow.
And meanwhile, olaparib blocks an enzyme the cancer cell uses to repair its own damaged DNA. Add in the pembrolizumab, which is an immunotherapy that strips away the biochemical camouflage the tumor uses to hide from the patient's own white blood cells, and you create a hostile environment from every possible angle.
So you blow up the cell, freeze its ability to divide, turn off its repair systems, and then sick the body's own immune system on whatever is left. That isn't just treatment, that is absolute overwhelming force.
It really is. This trial represents a massive paradigm shift in oncology. The sheer global scale of 268 sites and the staggering volume of concurrent interventions highlight a new foundational rule for aggressive cancers. Do not give a resilient tumor the chance to adapt.
Hit it with everything you have.
Exactly. By striking with this overwhelming coordinated force at the early stage, the goal is to eradicate any microscopic lingering trace of the disease before it can mutate a resistance or spread to other organs.
Incredible. So what does this all mean for you, the listener? We've just traveled across 3 entirely different domains of human health today. We looked at a 216-week preemptive strike on Alzheimer's disease, utilizing monoclonal antibodies to clear biological dry brush years before cognitive decline ever sets in. We examined a highly specialized 52-person cell therapy trial, literally infusing lab-grown cells into a liver to replace a broken survival alarm for our most vulnerable diabetes patients. And we just broke down a 2,400-person multi-drug global assault on aggressive early-stage breast cancer that refuses to leave anything to chance.
3 totally different diseases, treated with 3 very different mechanisms of action, but they are completely united by that incredible 18 out of 20 breakthrough score.
And even if you don't personally suffer from these specific conditions, these 3 trials matter to you. They are the living blueprints for the next generation of human medicine. This is the playbook now. The medical community is collectively moving away from purely reactive symptom management. We are demanding proactive, biologically targeted, and regenerative cures.
And as we look at these blueprints, consider the timeline of medical innovation we discussed earlier. We talked about how it takes 216 weeks, over 4 entire years, just to observe the statistical effects of an early intervention for Alzheimer's.
It's such a long time to wait.
It is, but it makes you wonder how many other quiet, slow-moving medical miracles are currently unfolding behind the scenes. Right this very second, in thousands of clinical trial sites around the world, data is quietly accumulating. Patients are patiently taking experimental doses, and researchers are just watching the charts, waiting for the clock to run out so they can change history.